Hi, everyone. This is Susan Lester. In the second session, we will discuss 9 more breast lesions. So let's get started. The first case is invasive ductal carcinoma. The histologic features to look for are raggedly infiltrative nests of tumor cells present in stroma in the absence of a basement membrane and myoepithelial cells. The pattern of the tumor is generally scattered and disorganized. A desmoplastic stromal response is almost always present. Look for tumor cells infiltrating around normal epithelium and sometimes into adipose tissue. You can also look for lymphovascular invasion, perineural invasion, or invasion of skin or skeletal muscle, showing that this is an invasive cancer. When you look at this section, you can see here there's very extensive DCIS. In some areas, the DCIS has distorted the lobules, so it looks like a duct. In other areas, you can still make out the remnants of a lobule. So it hasn't quite completely replaced the lobule. But as you look around, the stroma is mildly cellular, but for the most part, doesn't look like it's involved until you get down in here. Now you see these little nests of tumor cells. You see there's a stromal response. If we look on higher power, so here's a representative nest. Here are the tumor cells. You can see they're in direct contact with stroma. So this is definitely invasive carcinoma. You can see the stromal response around it. So these are the cells that are capable of getting into lymphatics or blood vessels and metastasizing. In contrast, you can see this area of DCIS. And remember before we talked about DCIS being like a tiger in a cage. So both these cells and these cells can be exactly the same biologically, but these cells are effectively in a cage of this basement membrane where these cells are out of the cage. So it's like being at a zoo. As long as the tiger's in the cage, it can't hurt you, just as DCIS can't metastasize. But as soon as the tiger's out of the cage or it's invasive cancer, then it has the potential to be able to metastasize. So the differential diagnosis, the one you have to really watch out for is sclerosing adenosis, especially if it's involved by DCIS, LCIS, or apocrine metaplasia. This is the most common benign lesion mistaken for invasive carcinoma. When you see it, it has a more organized pattern. It's swirling with back-to-back glands, so it doesn't sort of dissect into the stroma. It often has circumscribed margins. It usually does not involve adipose tissue, but in difficult cases, you may need to use immunohistochemical studies for myoepithelial cells to be sure. You can also sometimes have trouble distinguishing DCIS from invasive carcinoma. In this case, the involved spaces are well circumscribed. They don't have an infiltrative pattern. There's usually an absent or certainly a less prominent stromal response, but you may need to use immunohistochemistry to show myoepithelial cells. So it's important to note that ductal carcinoma is not a special histologic type. It, carcinoma of no specific type would be a better name. And it makes up 70 to 80% of breast cancers. It can range anywhere from low grade to high grade. And so within this group, it's important to know that they can be separated by ER and HER2 expression. So cancers that express ER and not HER2, so that's the majority, and we speak of them as being luminal-like or more similar to normal luminal cells. In contrast, we have the ER negative, HER2 negative group. So these are often called triple negative breast cancer because PR is usually negative as well. And this group overlaps by about 80% with cancers defined as basal-like, but these cancers are defined by messenger RNA, where triple negative breast cancer is defined by protein. And then we also have the HER2 positive group. About half are ER positive and half ER negative. So this is a good functional way to divide up these cancers of no special type. And it's important to know that the AJCC 8th edition staging for the first time, in addition to anatomic um, factors, also includes grade, ER, PR, HER2, and multi-gene assay results in selected cases. So the special type that's most common is invasive lobular carcinoma. So in contrast to most other cancers, these cancers lack cell adhesion. It's usually E. cadherin negative or with abnormal staining patterns. About 10% are E. cadherin positive, but they have defects in other cadherins. So the histologic correlate for calling something a lobular is this discohesive appearance. There may be signet ring cells. A single cell infiltrative pattern is most common, again, correlating with the lack of cell adhesion, but there are also solid and alveolar patterns. Grade ranges from low to high, and the desmoplastic reaction can be minimal or absent in lower grade types of invasive lobular carcinoma, and it's often associated with LCIS. So this is actually a skin biopsy. So this may have been a locally advanced cancer, or this could be a recurrence of cancer. It's important if the skin is over the breast not to call this metastatic cancer because this could just be locally invading. So you can see here we have this infiltrate. You can see it's infiltrating as single cells. If we look higher, this is very similar to the LCIS we saw in session one, because these are individual cells. They have these little nuclei. You don't even see nucleoli. They just have a slip of cytoplasm around them. And we may see, here's a signet ring cell here. So this is the mucin vacuole with the little droplet in it. So they're not always present and they're not specific for lobular carcinomas, but when you see them, um, it can be helpful. So your differential diagnosis, well, you should at least think of lymphoma, although lymphomas usually form solid masses of tumor cells rather than having a single cell infiltrative pattern. They're easy to distinguish by immunohistochemistry because they would be ER negative and keratin negative. Benign inflammatory cell infiltrates can resemble invasive lobular carcinoma at low power, so make sure you go to high power. Make sure that you're not looking at inflammatory cells. And then very rarely, a myofibroblastoma, the epithelioid variant, can very closely resemble invasive lobular carcinoma. And the majority of these are estrogen receptor positive, which can surprise people at some points. But actually, myofibroblasts often are positive for ER and PR. But the cells will be keratin negative. When you look at the tumors, there are usually spindle cells present, which you wouldn't see in a lobular carcinoma. The entire lesion has a circumscribed margin, and they don't involve normal breast epithelium, whereas an invasive lobular would almost always invade into normal breast tissue. So it is the most common special histologic type of invasive breast cancer, about 15%. If you look at grade 1 and 2 lobulars, almost all are ER positive and HER2 negative. If you start looking at grade 3 invasive lobular carcinomas, some of those will be ER negative and or HER2 positive. The majority of lobular carcinomas form masses with irregular margins like ductal or no special type carcinomas, but there is a subset that's very difficult to detect by imaging because of a lack of a desmoplastic response, so they don't create a mass. These cancers can present as architectural distortion or enhancement by MRI, but lobular carcinomas are the most common breast cancers to present as a occult primary. It's interesting that germline mutations in E. cadherin confer a risk of gastric signet ring cell carcinomas, and this is familial gastric cancer. So the two cancers, gastric signet ring cell carcinoma and invasive lobular carcinoma, can look very similar morphologically, although they're very different cancers. And a few of these patients with this syndrome develop invasive lobular carcinoma, but interestingly, most women with invasive lobular carcinoma do not have germline E. cadherin mutations. So case 12 is invasive micropapillary carcinoma. So micropapillary refers to a hollow ball of cells that resembles an inverted tubule on cross section. So you see this ball of cells with a central empty space. So it's the empty space is where, if it was a true papilla, That is where the fibrovascular core would be. The apical portion of the cells, sometimes with apricot blebs, faces outward. These tumor cell nests sit in clear spaces filled with serous or clear fluid, and these cancers are very commonly associated with lymphovascular invasion. So, this is an interesting case because you have both a micropapillary carcinoma here, and you have these areas of lobular carcinoma. And these are histologically very distinct. So, this patient probably has two biologically separate cancers. If we go way up on the micropapillary carcinoma, this is the inverted tubule pattern. So you can see this central hollow space. So again, if this was a true papilla, there'd be stroma and a blood vessel. You can see the apical blebs are on the outside. And if you wanted to stain this, you could stain it with EMA or MUC1, and that would stain the surface. So what this is it's actually anchorage independent growth, and it's a hollow ball of cells that you've cut across. I showed you in the first session sort of a similar structure in micropapillary DCIS, but we don't think that they're actually related to each other. And you can see in some other areas of this tumor, you don't always see the hollow ball. Sometimes these are little solid nests, but this is a nice one in that there are so many of these hollow balls of cells present. So here, if you look at the DCIS associated with this cancer, it's actually a cribiform pattern. So you actually don't see micropapillary DCIS associated with invasive micropapillary carcinoma very often. So we think they're not necessarily biologically related. It's sort of a morphologic mimic of these two structures to each other. And then here's lymphovascular invasion. So again, because this is anchorage independent growth, and you often see these structures in pleural fluids, so they're probably very capable of living in lymphatics. And so it's also very highly associated with lymph node metastases. So this is a relatively poor prognostic special type. If we look at her other cancer, here's her lobular cancer. So we see, as before in the previous case, you see the single cells. Here you see a beautiful mucin vacuole with a little red droplet. So this is one thing that distinguishes them from the gastric signet ring cells, because they usually have a mucin droplet, but it's filled with many fine vacuoles. So it's not 100%. You can see both types of signet ring cells in both cancers. But certainly if you saw this type of cell in a gastric biopsy, you should at least think about it. Metastatic lobular carcinoma to the breast. And if you make that diagnosis, you will be a pathology star. So what's the differential diagnosis for invasive micropapillary carcinoma? Well, it could be just stromal retraction around tumor cell nests. And so you can use immunohistochemistry to show the apical surface of the cells is facing outwards rather than towards the inside of the empty space, which would be the case if it was actually a tubule. But you don't have to do this for diagnosis. There's also a rare invasive mucinous micropapillary carcinoma. So at least 50% has to be the micropapillary pattern. Instead of serous fluid, it's mucin. And in these cancers, the prognosis is between a pure mucinous carcinoma and a micropapillary carcinoma. You can also think of a true invasive papillary carcinoma, but in this case, there would be fibrovascular cores in the papilla. So think of this cancer as growing in a way that its ability is to grow without being dependent on being anchored to stroma. And again, the same pattern is seen in pleural effusions. It is associated with adverse prognostic factors such as lymphovascular invasion and lymph node metastasis. And for grading, these inverted tubules are not considered true tubules, so the tubule score would be 3. All right, moving on to another type. So this is now called invasive breast carcinoma with medullary pattern. That's according to the 5th edition WHO. So these are interesting cancers because they form a mass with circumscribed margins. The tumor grows in sheets of at least 7 cells across. So this is called a syncytial pattern, but it's not a true syncytium. Each cell has its own cell membrane. They're all grade 3 because there's no tubules. They have a high nuclear grade and a high mitotic rate. There's a prominent lymphocytic infiltrate. There may be necrosis. And DCIS and lymphovascular invasion are usually not seen or are scanned. So it's a distinct type of invasive cancer. So here's an example. You can see at this power, it looks circumscribed. You can see it's blue. A lot of this blueness are the lymphocytes. Here you see the border. So there can be sort of this microscopic infiltration, but you can see in general, this looks like a circumscribed mass. This is a syncytial pattern, so you can see there are these large bands of cells. You don't see it splitting up into little nests like we saw in the invasive ductal carcinoma. You can see there are high-grade nuclei. You can see there are frequent mitoses. There's necrosis, and you can see this dense lymphocytic infiltrate. Now, the DCIS that may be associated with these medullary feature cancers can be quite subtle, and this is also true for other triple negative cancers because these are a form of triple negative cancer. So, way out on the side of this cancer, you can see these little areas here. You can see the lymphocytic infiltrate, and so that's usually a giveaway. Somehow the lymphocytes know where the DCIS is, but you could just easily pass over this. And it's only, oops, and it's only when you look at high grade, you can see the high grade tumor cells that are in here. And triple negative DCIS is often present as a clinging pattern and can be hard to appreciate unless you're really looking closely for it. So the differential diagnosis would be carcinoma without medullary features. So in fact, the original diagnosis of medullary carcinoma was difficult to reproduce. And so it was demoted in the 5th edition to invasive breast carcinoma with medullary pattern. So it's still important to recognize, but it's hard for pathologists to reproduce this diagnosis consistently. You should also consider could this be a metastatic carcinoma to an intramammary or a low axillary lymph node, particularly if this is a cancer up in the high upper outer quadrant of the breast? So you don't want to make that mistake. So don't call it a definite lymph node unless you see a definite lymph node capsule. You should also look for normal breast tissue or DCIS within the mass. That would also eliminate a metastasis to a lymph node. So these cancers are interesting because this is the most common histologic pattern associated with carcinomas from patients with germline BRCA1 mutations. Almost all are negative for ER, PR, and HER2. And the interesting thing about them is prognosis is more favorable than non-medullary pattern carcinomas matched for grade and size. And it's thought that this is probably due to the presence of the tumor infiltrating lymphocytes and the necrosis. We know that both of those features are associated with a more likely response to chemotherapy. One concern about the name was it was sort of people thought of medullary cancers as being of good prognosis. So they're better than other triple negative cancers, but they actually don't have a good prognosis, certainly not to the extent where you would consider not treating them with chemotherapy. So now moving on to our 14th case, encapsulated papillary carcinoma. This carcinoma usually forms a solitary mass with circumscribed margins. It consists of delicate arborizing papillae lined by a monomorphic cell population. You can have solid and cribiform areas. There's a circumferential zone of fibrosis. And interestingly, there are no myoepithelial cells present at the periphery or in fibrovascular cores. So this is in contrast to the benign intraductal papilloma we saw earlier. So here it is. So this is sort of a classic type. So it's a single solitary mass sitting in a space. When you look at the edge, so actually it's hard to tell on H&E, and so normally you would do immunohistochemical markers, but there's no myoepithelial cells here at the edge, and there are no myoepithelial cells in the fibrovascular cores. There is kind of this delicate capsule around the edge. If we look in a fibrovascular core, so here's a true papilla because here's stroma, here are vessels. And if you look at the base of the cells, there are no myoepithelial cells here. Again, normally you would do immunohistochemical studies to prove that there are no myoepithelial cells here. A pitfall is because these vessels can closely oppose the basal portion of the cells, so you don't want to do one of the muscle markers for myoepithelial cells and mistake these endothelial cells as myoepithelial cells. So in this setting, P63 is a much more helpful marker for determining that no myoepithelial cells are present. You can also notice um, compared to a benign papilloma, the cores are very thin, they're delicate. You can see a few that are thicker here, but for the most part, you see delicate cores and you see this monomorphic cell population. There's always a concern when you have a lesion without myoepithelial cells, could there be invasion? And you can see entrapment of ducts around the edge. But if these areas don't extend beyond the capsule, these lesions have a very good prognosis. So what's the differential diagnosis? Well, first, papillary DCIS. In that case, you would see myoepithelial cells present at the periphery, but not in the fibrovascular cores. Whereas in EPC, myoepithelial cells are not present at the periphery or extremely scant. Could this just be a benign papilloma? Well, a benign papilloma would have a more heterogeneous cell population. You could use high molecular weight keratin and ER, which would show this heterogeneous staining pattern, where EPC would be negative for high molecular weight keratin and show diffuse strong positivity for ER. Papillomas usually have thicker fibrovascular cores, which can be collagenized. And in this case, you would see myoepithelial cells both at the periphery and in the fibrovascular cores. If you're considering invasive carcinoma, again, there must be a frank pattern of invasion beyond the fibrotic rim of the EPC. So again, if it's a classic EPC with no frank invasion, it has a very favorable prognosis, similar to DCIS. So in spite of it not having any myoepithelial cells, it's classified as TIS or just like DCIS. There are rare lesions that look like this, but they have high-grade nuclei and a high mitotic rate. And in this case, classification as invasive carcinoma is recommended. If invasive carcinoma is present associated with an EPC, the size of the EPC is not included in the size used for T classification. So for example, if you had a 2 centimeter EPC, but a 5 millimeter area of invasion, you would only use the 5 millimeters for classification. All right, solid papillary carcinoma. So this has some similarities to encapsulated papillary carcinoma. However, solid papillary carcinoma usually involves multiple circumscribed clustered spaces instead of a single space. You see small fibrovascular cores present within the solid proliferation of tumor cells. The tumor cell proliferation can appear heterogeneous. There can be a spindle cell pattern, there can be signet rings cells, there can be mucin production, and that can make interpretation challenging. But the intervening stroma between the involved spaces is usually normal in appearance and does not appear desmoplastic. So here's an example. So in contrast to the previous EPC, you can see multiple areas are involved. These are the little fibrovascular cores, so you can see here. So it looks like, if you had a papilloma growing in a space, but the epithelial proliferation has become so extensive that it's now completely filled the space. And if you look closely again, myoepithelial cells may or may not be present. In a true solid papillary carcinoma, they will not be present. This is also an unusual case because although the cells look somewhat heterogeneous with these cells with this large cleared out cytoplasm, they look like globoid cells. So you see these more commonly, this dimorphic pattern in papillary DCIS, but here we're seeing it in a solid papillary carcinoma. More typically, you might see spindle cells or signet ring cells. You can see some mucin formation here, which again is commonly seen in solid papillary carcinomas. In fact, this may be some mucin in these tumor cells. So when you do myoepithelial cell markers, you may or may not see them out at the periphery, and you may or may not see them in these fibrovascular cores. Ultimately, in deciding whether this is um, an invasive carcinoma or not. You're looking for frank patterns of invasion. You're looking to see if any of these nests are going in and around normal tissue. You're looking for a desmoplastic response, which we don't see here. So the differential diagnosis would be solid papillary DCIS. And again, these lesions would have myoepithelial cells at the periphery, although they may be sparse, and you may need to do multiple myoepithelial markers. You can also think about solid papillary carcinoma with invasive carcinoma. So, this would be a case in which there's a frank area of stromal invasion um, associated with a typical solitary papillary carcinoma. So, a lesion like we've just seen, but then off to one side, there's a definite invasive carcinoma. Or you can think of, could this be invasive solid papillary carcinoma? In this case, you think essentially the entire lesion is invasive, and that's because the tumor cell nests are irregular. They look like they're in a jigsaw pattern, kind of fitting together, but very irregular. These tumor cell nests may infiltrate around normal epithelium, so that's something you normally would not see. And there's often a desmoplastic stromal reaction. So these are rare, but in that case, the entire lesion would be considered invasive carcinoma. So, solid papillary carcinoma without frank invasion has a very favorable prognosis similar to DCIS. And this is true even though myoepithelial cells are completely absent. So, like encapsulated papillary carcinoma, in this case, it would be classified as TIS or DCIS. It's also interesting to note that solid papillary carcinoma and mucinous carcinoma are closely related by gene expression profiling, and both commonly express neuroendocrine markers such as chromogranin and synaptophysin. And in some cases, you see the spindle cell pattern in solid papillary carcinomas. It looks very neuroendocrine. Okay, case 16. So this is a very rare diagnosis of the breast, microglandular adenosis, very distinctive. These are small round tubules formed by a single cell layer. The cells have uniform low-grade nuclei. The lumens have dense eosinophilic secretions, and the tubules are scattered throughout breast tissue with no or minimal stromal response. So here's the case. You can see most of this looks like normal breast tissue. You can see there's something going on over here. And if we look down, you can see all of these little tubules. And even from this point of view, you can see the eosinophilic secretions, and you can see them scattered throughout. There's some normal lobules in here. So it looks like if you just had a basket full of these little tubules and you just like threw them down onto the breast. So they're just sort of scattered everywhere. There's no pattern to it. There's no stromal response to them. If we look closer, now you see, so for the most part, it's a single cell layer. They have these sort of bland nuclei. They have these really dense eosinophilic secretions in some of them. So this is a very characteristic of microglandular adenosis. Here we see in contrast, here's a normal lobule. So these are the normal luminal cells. You can see the myoepithelial cells that have cleared cytoplasm and these sort of little dense nuclei. And these are the cells of microglandular adenosis. So microglandular adenosis does not have myoepithelial cells and it has this very infiltrative pattern. So it's a very interesting lesion. So the differential diagnosis, well, could this just be sclerosing adenosis? So usually in sclerosing adenosis, the glands are angulated and back to back, but occasionally you'll see sort of wandering adenosis that goes off into the stroma. So if that's in the differential, make sure you do immunohistochemistry to show a myoepithelial cell layer. Also, sclerosing adenosis, the cells will be positive for ER, where microglandular adenosis is ER negative. A more common differential is well differentiated ductal carcinoma, but again, this would be ER positive, whereas microglandular adenosis is negative. You should consider atypical microglandular adenosis. So, in some cases, the cells have a higher nuclear grade, they form solid nests, there may be mitoses. And you can also consider actinic cell carcinoma. This is a very rare type of carcinoma. In this case, some of the cells have coarse granular eosinophilic cytoplasm. The cells are positive for lysozyme, amylase, and alpha 1 anti-chymotrypsin. But in fact, there are lesions where it's really hard to distinguish between actinic cell carcinoma and microglandular adenosis. So, interestingly, microglandular adenosis is negative for ER, PR, and HER2. S100 is strongly positive. It does have TP53 mutations, and there are no myoepithelial cells are present. So you might say, well, then why is this being classified as a benign lesion? Well, it's because even though it has these features that would suggest it's an invasive carcinoma, it does not metastasize. The subset of microglandular adenosis is likely a non-obligate precursor of invasive carcinoma, and indeed, there have been cases where the microglandular adenosis and associated invasive carcinoma had the same TP53 mutation. About a third are associated with an invasive carcinoma at first diagnosis. The associated invasive carcinomas are typically also triple negative. They're also S100 positive, and they may be of unusual histologic type, such as adenoid cystic, secretory, or metaplastic carcinoma. MGA can recur locally, and some are associated with invasive carcinoma when they recur. All right, so we're moving out of the epithelial tumors, so that is most of breast pathology, but there are occasional stromal tumors as well. So the phylloides tumor has a biphasic pattern. So the neoplastic stromal cells arise from intralobular stroma. And because of that, when they grow, they also bring along benign epithelial cells, which are non clonal. When there's an intracanalicular pattern, this causes these elongated, distorted clefts, which we're used to seeing. And so these form the leaf like or phylloides appearance. So phylloides means leaf like. In the pericanalicular pattern, in this pattern, the epithelium is surrounded by tumor cells. So this gives the lesion a more solid appearance. There's a range of appearances from benign to borderline to malignant. And so we try to sort these lesions into these three categories, although in fact it's a spectrum. How you divide them into these three categories is based on a constellation of findings, including nuclear pleomorphism, cellularity, stromal overgrowth, mitotic rate, invasive pattern, and heterologous malignant elements. So in this phylloides tumor, so right away you can see the leaf-like pattern here. So this is the intracanalicular pattern. So you see these big clefts. As these get large, these can look leaf-like either on imaging or on gross evaluation. You can also see it's fairly dark, so that it's pretty cellular. You can see it looks like there's some expansion of the stroma, so there's some degree of stromal overgrowth. So you want to look at the cellularity of the stroma. You want to look at if there's nuclear pleomorphism, and you want to look at for mitoses. So here I found one for you. So here's a mitosis, and you'd want to count how many there are. Also want to look at the margin. So here's an area on the margin where the tumor's going into fat. And so this is an infiltrative margin. So just based on this, so this would exclude calling this a benign phylloides. So this is has enough features that would get you at least up to borderline. But unless you really saw heterologous malignant elements, it would not qualify as malignant. You do want to look very carefully when you see adipose tissue in a phylloides tumor to make sure whether this is invading into normal fat or if this is actually a sarcomatous part of the tumor itself. So the differential diagnosis is with another member of this family, uh, the fibroadenoma. So fibroadenomas overlap in features with benign phylloides tumors, but it lacks the features that favor phylloides tumor. For example, you wouldn't see increased mitoses, stromal overgrowth, or an infiltrative border. You could consider spindle cell sarcoma because that will overlap in features with a malignant phylloides tumor. So the only good way to distinguish those two is to identify the benign epithelial component to identify the lesion as a phylloides tumor, but that can take very extensive sampling. You could also consider spindle cell carcinoma because this can also overlap in features with malignant phylloides tumor. And here, immunohistochemistry for broad spectrum keratins, including high molecular weight keratins and P63, can be helpful to identify the lesion as a carcinoma instead of a phylloides tumor. So, interestingly, there are mutations in MED12 in both fibroadenomas and phylloides tumors. Important to know that only the neoplastic stromal cell component metastasizes because the epithelial component is benign. Malignant heterologous elements may be present, so pleomorphic liposarcoma, chondrosarcoma, osteosarcoma, or rhabdomyosarcoma. So, seeing these patterns, if you ever see any of these in the breast, they're more commonly associated with either a phylloides tumor or metaplastic breast carcinoma rather than true primary sarcomas. And so, to call a phylloides tumor malignant, you really want to see a malignant heterologous element. So, one thing to be aware of if you see well differentiated liposarcoma like areas in a phylloides tumor, they're very interesting because they lack the MDM2 or CDK4 amplification seen in liposarcomas elsewhere. So, they appear not to be exactly the same as other liposarcomas. In this situation, the likelihood of metastasis is low for phylloides tumors with this type of heterologous element. Therefore, if all you're seeing is a well-differentiated liposarcoma-like area, this would not be sufficient for classification as a malignant phylloides tumor, and it could be classified as a borderline tumor. All right, now we're up to our last case, or angiosarcoma. So the breast is the most common site for angiosarcomas. So they most commonly consist of abnormal blood vessels. They're in an irregular anastomosing pattern. The nuclei are usually hyperchromatic and atypical. You can see tufting in solid areas. The vessels dissect through stroma and invade through lobules, and extravasated blood forming lakes are common. You can also see epithelioid types of angiosarcoma that consist of solid nests of high grade tumor cells, and vessel formation may be subtle or absent. So you may require immunohistochemical studies to identify these as angiosarcomas. This is kind of an odd case. You can see the tissue here. You can see it's mostly going through fat. Um, but it's mostly a spindle cell lesion. So it's probably something to keep in mind that sometimes vascular formation can be hard to see. There are little vessels here, but it can be hard to tell in these spindle cell patterns whether these are truly blood vessels or sort of a spindle cell lesion invading into fat. Here you can kind of make out these little vessels, but this is one in which you would want to do immunohistochemistry to really show that the neoplastic cells are spindle cell endothelial cells. You also want to note that the lesion is infiltrating around normal breast tissue, so certainly any benign um, blood vessel forming lesion would be out of the question, like a hemangioma. So this is clearly a malignant spindle cell lesion. You would use immunohistochemistry along with the appearance that there are vessels in here, although they are poorly formed. There's maybe a little blood lake. That this is truly arising from endothelial cells. So the differential diagnosis would be with benign vascular lesions. We see capillary hemangiomas, which are well-formed clustered small vessels. You can also see cavernous hemangiomas in the breast, and these have large, thick-walled vessels. The lesion most commonly mistaken for angiosarcoma is papillary endothelial hyperplasia, or Masson's lesion. These are just an organizing thrombus with a complex spindle cell pattern. The trouble is it's fairly rare for these to present as mass-forming lesions, so people may not have seen them before. They usually form a mass with circumscribed margins. It does not involve normal breast tissue, so you wouldn't see it sort of in and around normal epithelium. It may be seen at sites of prior trauma, but that can be absent. So when you're seeing something, before you diagnose it as an angiosarcoma, normally you're going to be able to see it infiltrating around normal tissue. Can also consider atypical radiation associated vascular lesions. These occur in the skin after radiation exposure. They will lack nuclear atypia and they're MYC negative. Also consider pseudoangiomatous stromal hyperplasia or PASH, but we saw an example of that with gynecomastia. So in here, there are these slit-like spaces, but they're not filled with blood and they're not being formed by endothelial cells. So there are two types in the breast, which are very interesting. So the primary angiosarcomas occur in younger women, almost never men. So the one that we saw here involved the breast parenchyma, so it was probably a primary angiosarcoma. So secondarily, they can involve the skin, but usually they're deeper in the breast, and they're MYC negative. The radiation-associated angiosarcomas usually occur in older women after radiation therapy for breast cancer, and they can occur in just 5 to 6 years after treatment. They usually occur in the skin, secondarily can involve breast parenchyma. Interestingly, they're MYC positive, and they're often preceded by these atypical radiation-associated vascular lesions of the skin. And that wraps it up for the second session. I I hope you found them helpful. Thank you for your attention and good luck on your boards. Bye bye.